Jane is going to be doing a presentation. Jane is Associate Director of Public Involvement, Brighton and Hove NHS Clinical Commissioning Group. Oh, you've got a lot to answer for.
Thank you, Geoffrey. And I have to say that that is slightly wrong. I started my career down here in the Brighton Hove Clinical Commissioning Group. And it seems to have expanded. It expanded to a number of other clinical commissioning groups. And now I find myself in the dubious position of a role across our health and care system, which is great. So as it says there, I'm Jane. I was given the title of a shared understanding of engagement. Interesting one. So I thought I'd start off by thinking about what is this thing that we're calling engagement, just to frame our conversations. And there are many different terms that we use. We use engagement, involvement, participation, and a raft of other terms. But one of the most useful things that I've found to try and explain it is this spectrum. And it really shows that part of engaging people is by giving people the right information about something, enabling them to make a choice about maybe their own care or to participate in something. And then it's about listening to people. We're very good at listening to people in the NHS. Well, I think we are. And when we do engagement, we can go and talk to people and understand and then come away and say, well, they were people's views. But taking it to the next stage is when you discuss with people. So it becomes more than just, what do you think about that? Or could you fill in our survey? It's actually something a bit more interactive with people. So you're drawing people with you. And then moving on to doing things totally with people is collaborating. It's not just about having discussion, it's actually working with people, with our patients, our carers, our communities over a period of time. And then ultimately, on this spectrum, we look at empowering or removing the barriers to empowerment. So actually, how can we be supporting people to do things for themselves? So when we talk about that word engagement, it's not simple, it's a range of things. And that's the kind of definition that we're using across our system. We've produced a strategy. I think, what did you say, Geoffrey? Alphabetti spaghetti. Alphabetti spaghetti. Hopefully it's not alphabetti spaghetti, but we've got a strategy. You've always got to have a strategy. This is our strategy for working with people and communities. This is a strategy for our integrated care board, but also for our wider health and care system. We had to have it for the integrated care board. It was a requirement, but we wanted to do it anyway to really try and underpin how we're going to continue to reach and hear from people and communities. And it is a continuation. I think this isn't something new. This isn't something that's going to start on Friday that we're not doing on, what's today, Tuesday. So we're not doing it Tuesday and Wednesday, but we start it on Friday. We've been doing this work for a long time in Sussex. We've got we've got such a lot of insight. We've got relationships that underpin it. But this strategy is something new for our new way of working that really tries to draw all of that together. So as I say, it's a requirement. It spans the health and care system. And by the system, I include our voluntary community and social enterprise sector in that as partners, and Healthwatch, of course. We developed it together with those partners, and it builds on what we've got already. I don't expect you to squint at these, and I'm not going to read them out. You'll be very pleased to hear. And we will follow up with a copy of the strategy. But we've got 10 core principles, and I don't think there's anything here that you wouldn't expect to find, or that stands out as you think, oh, that shouldn't be in there for our strategy. It really shows our commitment to reaching and hearing from local communities, and not just hearing from, it's actually doing something as a result of that insight, of drawing that insight together, but also making sure that we can support people and communities to take action for themselves. I think it's easy to say across our health and care system, it's all just us, the NHS or councils, that we're the only ones that can do things. But actually, there is an awful lot that people and communities can do for themselves with the right support and funding. How many times have we heard the word funding this morning? With the right funding to be able to do that. So, just very briefly, the key elements of our strategy. First of all, it's insights. And what I mean by insight, it's what people and communities are telling us. there is a lot of a move to look at data at the moment. And by data, I mean the stats. But when you think about, there is such a lot that statistics don't tell us about our people and communities. They might give us an idea of where you've got a particular condition, health condition, that's worse than other areas. They might tell you, for example, as one of the things I recently worked on, how many people have or have not had their COVID vaccinations for some of our population. But it doesn't give you the whole picture. It doesn't give you the richness of people's life experiences, where people and communities are. So we will be systematically seeking that insight and building on what we've got already. And we've created something called an insight bank, which is a repository of that insight. So our system partners will be able to, when they're starting a project or they're starting a piece of work, say, what are our communities said about that already? And I know from my work with communities, there's nothing worse for people in a community when you go and say, can we just talk to you about this? They said, you asked us that last year and you've done nothing. So I'm not going to talk to you again. So it's really, really important to start with the insight that you've got. And you can only do that if you know where the insight is. We are pulling together the information that our NHS partners and other partners hold. So if you think about it, within the hospitals, community trust, mental health trust, they've all got a raft of information about the experience of their service users and their carers, whether that's complaints, patient advice and liaison service, friends and family test. We're going to try and draw that together. And we're going to try and look at not just the themes, but where the pinch points are between those services as well. This is not anything revolutionary. And I'm sure people are sitting thinking, well, don't they do that already? We do to some extent, but what we need to do is do that systematically so we can then overlay it by some of this community insight that we get. And we're focusing on solutions as well, not just, oh, here we are, here's a report, that's great, people think this. So actually, what do we do? What do we need to do as a system, and what can people and communities do for themselves and actually support those solutions as well? And also, insight captured by community members. So let's get people within those communities. It's not just about me going into a community, so can you talk to me? It's actually people in those communities who are gathering the insight. Then we've got asset-based working, taking a strengths approach to the work with communities. I think it's really, really easy to start with a deficit model and really think about what's wrong here. What do we know is lacking in these communities? The statistics tell us, oh, you're low on the uptake of this, or oh, that's, must be difficult. Actually, these communities have massive strengths in their people, in their assets. So let's start with that and use a strength-based model. Let's support our communities through small grants to be able to take some of those actions themselves or seek the insight. Let's develop things like lived experience network. I talked to Catherine, who raised the earlier point about lived experience. Really, really important is that lived experience is such an asset, but we need to make sure that we harness that in the right way and we support people to bring their lived experience to our tables. And then health inequalities. So this is where we've got communities whose health outcomes are worse than other communities. I think we could all, around this room, if we went around, we could all list some of the communities that we know have worst health outcomes and have barriers to access. So access to care is not as equitable as for other communities. This is one of our key aims for our new system, for our integrated care board, to reduce that inequity in our communities. And this is why the insight capture, working with people and communities, is so important. That if we don't reach out and hear from those people and communities, how will we know what the barriers are? But also, how will we understand what needs to be done to overcome those barriers? I think it's very easy to say, oh, well, there's inequity there. But until we know, we can't take that action. And I think the work on COVID vaccination has been such a good example of that, where we actually understood from some of the communities, which meant going down to real, not just town level, it was neighbourhood level, it was a couple of roads level, to really understand what people and communities were telling us and what would make a difference. And if what makes the difference is actually getting a van to come to your road, I say van, something a bit more sophisticated maybe, to deliver a vaccination, and having some community members design the posters and actually having community champions there to raise people's confidence. That's what made the difference and got people through the door. But we didn't know that until we asked the communities what would work. So we're going, as you will see there, I'm not going to go through everything, but we are going to do a range of things to make sure that we continue to hear from groups and communities who experience health inequalities, including work with some of my BCSE colleagues that I can see around the room, that we already fund to do that. It's really important, so massively important, that we go through trusted intermediaries in doing this work. And I think, hopefully colleagues will agree that we've had, a number of years of good funding and some success in actually hearing from these communities. So to support this work, we've got strategies, we've also got frameworks. I think it's another alphabety spaghetti moment, Jeffrey. So we want to do work with our primary care networks, so groups of GPs that work together with other services to look at the addressing health needs of neighbourhoods. This is where PPGs come into play. So I think Sylvia, where's Sylvia? Sylvia mentioned PPGs earlier, patient participation groups. They are really, really important in that engagement with communities and neighbourhoods and primary care networks. So really good piece of our engagement jigsaw. Our inclusive engagement is about health inequalities, systematic ways of reaching and hearing from people who experience health inequalities, systematic ways of bringing insight together, so all partners can use that when they're planning and responding to what people and communities say. Co-production, doing things with people, bringing people to work with our services, which might be commissioners, it might be providers or others, to work together. Co-production is not about having somebody with a lived experience just brought in and ticking a box. True co-production is much more than that. It's about working together. And we're starting to really get a good traction on that across our system. Lived experience I mentioned, and then we've got an evaluation framework because we want to know that we're doing this right. We want to know how we're doing against this strategy. But we also want to hear from our people and communities as whether we're doing well. I'm not going. This is the assurance and evaluation slide. So I'm not going to run through this in great detail. We've got an assurance process. We have a new patient experience committee, and I think Stephen said earlier we've got a chair of that who's an ex-chief nurse in our system. But importantly and crucially, we're setting up a working with people and communities evaluation panel. We didn't need to do that. There's nothing in the rules and regulations that said you need this extra level of scrutiny, assurance, check and challenge. But we wanted that because we think it's really important to have that independence. And Healthwatch are chairing that panel, which is great. We've had an exploratory meeting and we have people with lived experience. We've got members of our voluntary and community and social enterprise sector and others, and we're going to build that membership as we go. And that panel will be an independent review of, are we doing our job right against this strategy? So I will be giving a report, I'll say here's the report, but this panel will be the independent review of that, and we'll be telling our patient experience committee what they think about whether we're doing our job aligned to this strategy. So our partnership and collaboration with Healthwatch. I've worked quite closely with Healthwatch across Sussex for a number of years, and personally I think it's a really good constructive relationship. I'm looking at David. Good constructive, yeah, thumbs up from David, phew. Good, it's a good constructive relationship. But I think recognising that Healthwatch have a statutory function, independence, watchdog. So, we're not close because it's really important for Healthwatch to maintain that independence. But the way that I work with Healthwatch is thinking about what Healthwatch can bring to us in terms of hearing from patients, carers, and the public. Several times Healthwatch have flagged up things and said, you know what, we're starting to hear a lot of this through our helpline or as we go out. A bit worried about that. And it's an early warning for us. Similarly, Healthwatch will, what was the phrase, bang on about in the nicest possible way, And it's not banging on about it, it's keeping raising the things that people are concerned about. Dentistry, we've talked an awful lot about dentistry, and we continue to talk about it because Healthwatch are still hearing about dentistry. We may not have the magic bullet, the magic answer, at least not until Friday, Stephen. Is that right? Dentistry? Thumbs up from Stephen. We may not have the magic bullet now, but it's so important to know that our people and communities have difficulties, that that are still experiencing difficulties. So we know it needs to be a priority for us when we can take that action. Healthwatch also help with targeted insight capture. That is alphabetic spaghetti. What I mean by that is, if there's a particular thing we need to hear about, a particular service, then Healthwatch can sometimes do some of that engagement through their routes and contacts and actually then tell us what people are thinking. Healthwatch, of course, are also a critical friend and constructive challenge. That is one of Healthwatch's role. When I say critical friends, there are a number of different ways that we've involved Healthwatch in, for example, looking at our communications materials. And the input from Healthwatch colleagues has been amazing in terms of, actually, you've not framed that quite right for the public, or we need to do that slightly differently. So the advice of Healthwatch has been absolutely crucial in those kind of things. And of course, constructive challenge, because we don't always get it right, always. But it's really important that Healthwatch are challenging the NHS, the wider system, social care, to say, what is it you're doing? Why are you doing that? And that's the beauty of Healthwatch. And that's when I was thinking about it, how I would see what I see as the main ways that I work with Healthwatch. Now, I know there are a few questions that were fed in beforehand, which is about kind of the range of ways that we do this thing that we've called engagement. And again, I'm not going to read out all of those, but I tried to represent that it's not just about surveys. It's not just about going and standing in Crawley Shopping Mall and talking to people. It's not just about a panel. There are so many, it's like a jigsaw. There is a range of ways. They might be face-to-face. We've certainly got more expert on digital work over the past 2 years, but you do all digital, you exclude people. You do all face-to-face, you exclude people. So you would need a mix. Working with our voluntary and community sector, we have a legal duty to do formal public consultation in some instances, which we do, I think, remarkably well. Experts by experience, lived experience, so a range of ways. It's not one size fits all. And I think, I think one of the questions was, what about young people? Ed, what about young people? Ed, Amy? But actually, when somebody said, well, how are you going to engage with young people? My first, I'm not young anymore. I was once, a long time ago. My first reaction would be, I'm going to go and ask young people. So I'd probably come to Ed and Amy and say this question, can you advise us on how best to do it? I would imagine it's a mixed method. Again, I would imagine if we set up a children, young people sort of people's panel that can feed in remotely, that might be one good way of doing it. But you need to balance that with, I would imagine, going to where young people are, which might be colleges, pubs. Oh, no, not pubs, scrub pubs. But yeah, we need to go where people are. I think that's the most important thing. If we want to go and talk to people, we need to take advice on what's the most appropriate way and make sure we can go and get that insight. So underpinning all of this, partnerships and collaborations. This is not something that I can do on my own. There are people that do this kind of work across our system, whether it's in hospitals, mental health trusts, our local authorities, our district and borough councils, voluntary and community sector. If we want to really hear from people and make the most of the limited resources that we've got to do this work, but also to really maximise the gains for our community, we need to do this together. That's why collaboration is so important. So we're going to build on what we've got already. We're not going to go and create new things on Friday morning or even Friday afternoon. We're going to create or build on our place-based people's networks and local engagement groups that already exist. We're going to develop a patient experience leads network, which draws together work across our NHS providers. Remember I said about the complaints, patient advice and liaison service, etc. Actually, let's create a network and do some of that work together. So it's all about collaboration. It's all about partnership. It's all about, if we want to hear from people and communities, how can we do that together? How do we build on? How do we share the insight? And then finally, I took a quote from our NHS England guidance, working with people and communities, about what our health and care system will do. It will listen consistently to and collectively act on the views, experience and aspirations of our people and communities, which includes supporting people to sustain and improve their health and well-being, involving people in plans and priorities, and continually improving services. I think that really underpins it. It's not just about this thing called engagement, where you reach and hear from people. I think that underpins it for me. It's a spectrum. There are different ways of doing it. It's about collaboration. And ultimately, it's about getting better outcomes for people and making sure our services meet their needs. Thank you. I think I'll pass back over to Geoffrey.
Okay, thank you very much.